it to me. I can make sure it gets pulled up over here.
How are you?
So tired.
Anything in particular, or just in?
Take your pick, really.
Recording in progress.
Everybody ready? All right. Morning, we'll call the August meeting of the Douglas County Board of Health to order. Official notice of the meeting from the Daily Record here. There's a copy of the Open Meetings Act there at the west table. And with that, roll call.
Wade.
Here.
Gray.
Here.
McNally.
Here.
Rogers.
Here.
Weiss. Here. Wilkin. And Espinoza.
And I don't know who's online, but just for the record, those online can be marked present, but can't be counted as the quorum. With that, we'll go to item 2, an approval of the minutes. Letter A is a vote to approve the July minutes. Is there a motion? Motion by Gray. Second by Weiss. Roll call.
Okay, Wilkin.
Yes.
Wade.
Yes.
Rogers.
Yes.
Weiss. Yes. McNally.
Abstain.
Espinoza. Yes.
Item 4 is approval of action items. I need to remove B to take that separately, and if there's no other need to remove, is there a motion to approve the action items without B?
Motion to approve item A and C through M.
Motion by Gray, is there a second? Second by Weiss. Roll call.
Gray.
Yes.
McNally.
Yes.
Rogers.
Yes.
Wilkin.
Yes.
Espinoza. Yes. Weiss. Yes. And Wade.
Yes.
Is there a motion to approve item B?
Motion approved.
Motion by Gray. Is there a second?
Second.
Second by Wade. Roll call.
Okay, Espinoza. Yes. Gray.
Yes.
McNally.
Yes.
Rogers.
Abstain.
Wade.
Yes.
Weiss. Yes. Wilkin.
Yes.
Go to item 5 and the Health Director's report. You.
Morning, board.
Morning.
Morning.
Welcome to August. We have quite a busy agenda today, so I am going to try and make this as quick as possible. Along with my COVID report after the personnel report, I've actually asked a couple of my staff to be here to talk to you very briefly about monkeypox to make sure that we have a good idea what's happening on that front. So in terms of personnel for July leading into August, we had a few people who left the department. Megan Krajcek, who's been one of our epi disease investigators, is moving on effective August 19th. Anania Caruso, who was one of our food safety inspectors, has left the department. Lorraine Petterite, who is one of our secretaries down in environmental health, she is our secretary for the sanitation control section, has submitted her retirement in September. And we did have a few more temps who just finished their COVID assignments and so are no longer with us. We've also had a few new hires this month. Celeste Salazar is being hired for the disease investigator position that's been open in STI and EPI, so we welcome her. She's starting on August 22nd. Tamara Riviera is being hired for the environmental health specialist 1 position in food safety. She's currently onboarding and will be starting in early September. And Kurt Morrow is actually taking the place of one of our emergency preparedness coordinators in early September as well. The person that initially I announced to you would be taking that position was unable to accept due to some issues back in her home country. So we are very excited to welcome Kurt and think he's going to be a fantastic addition as well. We also had a couple of promotions and transfers. So Michaela Ruma started as a secretary in WIC in health promotion, and then I have the pleasure of announcing to you today that we have filled the position for the chief of EPI and health data, or whatever we decide we want to call this section as we're restructuring Mr. Justin Frederick will be taking that chief position, and we very much look forward to his ongoing expertise and his commitment to really the work of that section. Justin has been absolutely integral in not only the COVID response, but really quickly jumping onto that monkeypox situation and ensuring that we as a department are aligned well to respond. So we're very happy to see him in that position. I also am happy to announce that we have filled at least offered our fetal infant mortality review position, which has been open for some time. So we're very excited about that. Supervisor for food safety and compliance, which has been open for several months. We do have interviews scheduled there. Emergency response coordinator, we have one more position open, and so we're scheduling interviews for that currently. I already announced to you the chief position that has finally been filled. The deputy director position just closed, and so we are working on assembling a panel and scheduling interviews for that, and I think we have some good candidates there. We will be also interviewing for the senior epidemiologist role, hopefully in the next coming weeks. And we also have the health equity epidemiologist position open, and we have several secretary positions that remain open. So I'm very happy to report that some of those kind of big gaps that we've had over the last few months are starting to fill in. So we're very, very happy about that. All right. Does anyone have any questions about personnel at this time? All right, great. I'm going to go ahead then and move on to our really brief COVID report. So I know everyone's kind of tired of talking about COVID, but I did want to provide a quick update there. So we have over the past few weeks, actually I would say the past couple months, we did have we had an increase in cases. So if you look at the chart, you're going to see that it appears that we're coming off of a bit of a wave. We did elevate to the high risk category for several weeks. We have now dropped down to the medium category, so that's good news. Hopefully we continue that trend moving downward. I do expect that we're probably going to see an increase in cases, at least temporarily, as school starts for many of our school districts. So I know Millard started last week, and we have others that are starting this week. So I will not be surprised if we do temporarily see these numbers go up. We are providing assistance to the school districts at whatever level they need it. So currently we are asking or recommending that they follow the CDC guidelines, and we will continue to work with them. You know, if they notice that they're having an outbreak or a cluster of sick kiddos, we'll help them in whatever way that they happen to need it for that situation. So the good news is that those numbers do appear to be going down at this time. Hospitalizations, you're going to see kind of a similar trend. So we were increasing there for quite a while. What I heard most frequently from the people who are part of the Healthcare Coalition that come together frequently was really that we were picking up cases of COVID that were coming into the hospital, but a lot of the times they were coming in for other things. So it was kind of a, something that they found. Not to say we didn't also have some people who were pretty sick with COVID coming into the hospital, but primarily when people were coming in, it was for other things, and then they were finding COVID as part of their assessment. And then you can see that yellow line, which has been essentially flat through this current wave, which is fantastic news. That's our ventilator usage. So that's the first time in the outbreak that we've really maintained for a long time through a wave, a very low level of need for ventilator usage. So that is fantastic news. And then we're sitting at 83 and 84% occupancy there, which is fantastic. All right. In terms of vaccinations, we continue to vaccinate the public. We are continuing to vaccinate ages 6 months through however old people are and want vaccination. So doing that and also providing boosters where people are eligible for that. In terms of being fully vaccinated, right now, out of all of our Douglas County residents, 67.2% are vaccinated. That is, of course, a number we would love to see higher. We'll continue to offer that and encourage that as much as we possibly can. So that is a very, very fast overview of COVID. Does anybody have any questions right now? Great. I am going to go ahead and call Justin Frederick and Leah Casanave up to talk to us about monkeypox and give you a quick briefing there.
Morning, everybody.
Morning.
Shut my phone off here. Okay, so it worked. Good. So here to talk to you this morning about monkeypox and answer any questions that you may have about the health department's response. I'm going to give you a little bit of an overview on the epidemiology, some of the clinical diagnosis treatment, and then a little bit about our collaboration with the vaccine. So monkeypox, rare infection. This is actually the first time that we've seen monkeypox in many countries around the world that are not endemic. In fact, I think there are only 6 countries of the 70 plus that have been reporting cases that are endemic. Signs and symptoms of monkeypox include a characteristic rash, and that's really been described to us as a kind of a deep-seated vesicle or pustule is what a lot of the clinicians are reporting to us. A lot of times these lesions are in different phases, so you may have some that are new, some that are scabbed over or even fallen off. Often there's prodromal symptoms, which are often mild, but would include fever, fatigue, malaise, lymphadenopathy, things like that. And then we are seeing some co-infections. Transmission, typically skin-to-skin contact, prolonged skin-to-skin contact, or through fomites. And they are reporting that there could be a potential spread through respiratory secretions if somebody has lesions in their mouth. We're not at this time seeing casual contact as a source of infection. This is a couple pictures from CDC just to kind of show you easily misdiagnosed. So it's really important that physicians collect a good history and physical on patients when they present. So worldwide, there are 38,000 cases. In the United States, we have 12,689, and that was just as of this last week. And I'm going to show you guys an epi curve here in a second because this has really exploded in the past few weeks. If we look at the end of July, we just had about 2,500 cases, so about 6 times that between the end of July and now. In Nebraska, we have a total of 17 cases. The majority of those are here in Douglas County, 3 in Lincoln, Lancaster, and then we have 1 in another county. All of our cases are males. Age range is 29 to 50 years of age with a median age of 38 and a half years. 10 of those individuals report MSM, or men who have sex with men, 1 heterosexual and 1 unknown as we continue to investigate that. This is just a picture of the United States where we have a lot of, you can see the spread of cases. Illinois, Chicago, New York City, Atlanta, Georgia, and I think even San Francisco now is reporting high levels of transmission, and many of these cities declared a public health emergency before the federal emergency was declared. This is that epi curve or epidemic curve I was telling you about. It ends on July 25th, but you can see the rapid increase in cases in our country. The United States is now reporting more cases than any other country in the world. And again, this was as of July 25th, and now we've got about 6 times the number of cases. I just wanted to show you this. We are doing whole genomic sequencing, which is pretty cool, and I would love to come back and talk about that another time. But we can actually sequence monkeypox specimens And that tells us a lot about transmission, whether it's independent introductions into our community or if we have ongoing community transmission. So, like many other diseases, although this one is a little more resource intense than COVID, we do case investigations on every case that's reported to us. And a lot of times we follow these individuals for 3, maybe 4 weeks before they're completely healed and able to return to normal activities. But again, resource intense, contact investigations, case investigations, we're collecting a lot of information on potential exposures and potential contacts, household and other. We do ask these individuals to voluntarily isolate, and again, this can be a really long isolation. We're talking 3, maybe 4 weeks on average is what we're seeing. Luckily, my section has been able to partner with Patty Falcone's section. She's the supervisor of health promotions, and they have the health navigators who have been assisting us with rent and food and utilities and things like that for our patients. We ask that the patients remain in isolation until all their lesions have scabbed and fallen off and there's fresh skin so that they're no longer infectious. And then they need to be seen by an ID doc or a physician to release them from that isolation. So far, everybody's been cooperative, I would say, but again, it's a long period of time for them. The case investigation and contact tracing, we identify individuals and we assess their risk, whether they have low or unknown risk, intermediate or high. And then that determines whether or not we move forward with post-exposure prophylaxis with vaccine. And so again, working with Leah's group and the clinic, and that's been going really well. We've also set up 2 different REDCap systems to monitor community contacts, and they actually receive a text message or email once a day, and then they report their temperature and symptoms to us. And then if they develop illness, we can reach out to them and direct them as to how best to seek care. We've also set up an additional REDCap system to monitor healthcare workers who have been exposed. So if they're not wearing the proper PPE, they may need to receive post-exposure prophylaxis and then also be monitored for 21 days. So far, we've identified 37 healthcare professionals that have had some level of exposure that we're monitoring or either received post-exposure prophylaxis and 36 community contacts. Monkeypox testing, at this time, Nebraska Public Health Lab is able to do that. The 3 of us up here, Dr. Hughes, Leah, and myself, we've been approving those tests for the last 2 months, 7 days a week at all times of the day. So NPHL is actually going to be switching their process so that doctors can order these tests directly, which is a huge sigh of relief for all of us. Right now, they're able to keep up with capacity, even though commercial laboratories are offering testing, such as LabCorp, Quest, and Mayo, et cetera. We would prefer that physicians continue to send to NPHL because it is about a 24-hour turnaround time, Monday through Friday. Treatment is with tecovirimat, or the TPOXX. From what we've seen, it's working. Patients in about 24 to 48 hours are reporting improvements in their illness. This is a FDA-approved, expanded access investigational new drug. So there's a lot of paperwork that goes with the TPOXX, and we have to work with the Strategic National Stockpile, just like we are with the vaccine, to receive that. So far, Douglas County, we have the majority of the state's supply of TPOXX locally, and we just ask physicians to reach out to us if their patients meet the CDC criteria for treatment, and we'll be happy to help facilitate that. Again, some treatment considerations: severe disease or co-infection, HIV, leukemia, lymphoma, things like that may be immune suppressing. So I'm going to talk really briefly about vaccine, and I'm going to turn it over to Leah. This is more her wheelhouse, but we collaborated on a project to distribute vaccine, and the purpose of the project was to create a fair and equitable system for the distribution of monkeypox vaccine to those at highest risk of infection, and that's using the latest EPI data without creating any additional stigma. If you've been following the news at all, you know this is disproportionately affecting men who have sex with men. And again, we have a responsibility, just with the limited number of doses of vaccine we have, to get those out to the highest risk individuals. So the state epi actually defined three, definitions or eligibility, if you will, for individuals to receive the vaccine. First is the post-exposure prophylaxis, which is anybody who is potentially exposed to somebody with monkeypox or had direct contact. He went on to define an outbreak response post-exposure prophylaxis, or PEP++, and this is people who may have attended an event or been somewhere where there was a case, but they don't know if they had direct contact with that individual. And then there's the pre-exposure prophylaxis, or PrEP. So anybody that's at high risk for potential exposure but has not yet had that exposure. So what we did, we actually developed a red cap assessment. We call it the Genios Vaccine Survey. And this is a way for individuals to register with us that may want the vaccine and get them into the system. What we did is we took, obviously, the post-exposure prophylaxis is our highest priority, then our post-exposure prophylaxis plus, or PEP++, is next, and then we have this entire group of PrEP, or pre-exposure. And we went on to define that as, you can see there listed, men who have sex with men, HIV positive, dating apps, or multiple partners would be like our tier 1, and so on. And again, this is really to vaccinate those individuals that are at highest risk using the epi data that's present right now. This could change tomorrow if the outbreak changes. Just real quickly, there's a lot of interest in the vaccine here. We've had 671 people respond to the survey so far. Leah's worked on getting that out to multiple groups. It's on our website, different FQHCs, etc. Broke that down even further. So post-exposure prophylaxis, we've had 18 folks register. PEP++, 44, and then the PrEP group is our biggest group with 504 individuals that have registered. And with that, I'm going to turn it over to Leah.
All right. Good morning. So, as Justin kind of started, we originally distributed this survey, a month and a half ago. I feel like it's been longer than that at this point. But he created the survey with his epi team, and we only had a very limited supply, about 75 doses. And that was with a partnership that we had. So we only distributed to specialty care clinics and very high-risk groups that really attend some of those specialty care clinics. And so that was kind of how we started, just because we had such a limited number. So now, as Justin mentioned, we have shared this survey. It's on our website. We presented it at a provider epi update similar to this one, as well as just our info lines handing it out. So really that survey is available to the general public at this point. So Genios is a 2-dose series with a second dose given about 4 weeks after the initial dose. If some of the immunocompromised folks, there's no contraindications, pregnant lactating people and children need a special approval. And actually children just got approved, so we don't need that special approval anymore. Contraindications, allergies to egg protein, gentamicin, ciprofloxacin, and any just precautions, not saying that they're not able to, but just to be aware, any history of mRNA vaccine in the last 4 weeks. So I'm not sure if in the news you guys have known, but this is a subcutaneous shot originally, and now there is an EUA to do an intradermal shot, which is a fifth of the medication essentially. So it's 0.1 milliliters given intradermally versus the 0.5, which is given subcutaneously. So,
Can you give that definition?
Yeah.
Please, for people?
Yes. So subcutaneous, further down in the arm, in between the fat, it's the thicker fat area, and then intradermal, top kind of layer of the skin. So there have been studies that have shown that this intradermal dose is basically working the same way as it is subcutaneously. So the good thing about that is it provides us with 5 times the number of vaccine that we've been given. So we have had some local collaboration between us, Sarpy-Cass, and Three Rivers, because we know that people cross borders. We know that there's people going in between all the different areas here. So we figured, why not just combine our resources and have one real central location, and we will treat whoever in our area. So our current inventory that we have is 125 doses, and that's of the subcutaneous, so the 0.5 milliliters. And we're anticipating an additional 100 doses sometime this week. Total, we have received about 377 doses to date, and we have given about 200 doses from our DCHD clinic so far. We have transferred to One World Community Health Center, Charles Drew Specialty Care Clinic with Nebraska Medicine, CHI Specialty Clinic, Mark Goodman's office, and we plan on scheduling about 100 additional doses with that Community Prep PEP++. And we are also working on scheduling and informing those community members in those 100 additional doses by pulling them from the survey and either calling them with some of our temporary staff that we've brought on and setting up actual appointment times, or letting them know that, yes, we've received your information, we'll be reaching out once more vaccine becomes available. So our current vaccine, kind of how we've been giving this out in our clinic, is at our STI immunization clinic on 41st Street. Tuesday's been 12 to 7:30, appointment only, and Friday 9 to 3, appointment only. And the staff involved with this is basically just our health department STI immunization team. So our upcoming plans, starting August 30th, is using the back parking lot at Douglas County and having it Tuesday 5 p.m. to 8 p.m. and Saturday 10 a.m. to 3 p.m. And staffing, we're working with VNA and hopefully some nursing school programs to get some nursing students in, just so that we can really get the number of vaccines out that we need to. Then we are also working with some other potential partnerships throughout town, basically looking at the high number of STI diagnosis clinics in Douglas County. And just a note that majority of this funding is now coming through in order to pay for some of our VNA and our own staff, coming through our state Vaccines for Children and COVID immunization funds. They have given approval to use those funds for monkeypox vaccinations. So if the community has any questions, our info line has been updated on all things related to monkeypox, and to date they have received 145 calls. They received in June, they received 2 calls, July 43, and so far in August they've received 100. So as you can see, kind of like the epi curve, we're seeing the same thing in our info line phone calls. We just keep getting more and more calls asking about where they can get vaccine or if they can get tested somewhere. So our info line hours, just a reminder, are Monday through Friday and 9 a.m. to 3 p.m. So then on here, we just put some contact information, and I think that's it. Any questions?
This may be more for Justin. I keep seeing dating app, like it was on the early things, and then the outbreak in, I think it was Spain. Are we collaborating? Probably this is more of a national thing. Are they using that dating app to get information out? I mean, or is there multiple apps? Do you know? I mean...
That might be more of a lead.
Oh, okay.
Actually.
I used to be in the STI world.
Yeah.
So actually with the dating apps, I know Phil has actually looked into it, of getting some media information out. We hadn't gone that way yet, just because, one, it is expensive, and it is going to take a large chunk of resources to do that, where we weren't sure if we were having funding. I actually just got approval for the funding like this week. So hopefully we can go down that path, but also we were unsure of how to promote it, just because we didn't have vaccine. Like they told us we were getting 300 doses this week versus now we have 100. So they cut us back by several. So that's kind of, we've looked into it. We haven't gone that far. I don't know if dating apps are promoting that information locally.
Also, like information, just basic information about the disease and spread? I mean,
I think nationally, there have been some efforts, and I want to say maybe Grindr. There are a number of different apps, but I do know that nationally somebody, I'm assuming the CDC has worked with them to put some like little pop-up ads that give some general information. So that would hopefully be helpful, but I don't know that that's happened with every single app. I think it's just probably the bigger ones.
And a lot of the apps, just from my previous work in STI world, they aren't big fans of health departments on their apps. That's why they tend to charge a lot for that. And there was one, I believe Scruff allowed us to do free advertising on there for a while because it was based out, it's a social worker that kind of started that. So they have some underlying interest in it, but then they've removed that and now since charge for ads to be in there. We talked about trying to do contact tracing through the apps. They won't let us in, so money business.
well, I kind of figured that much.
What's you all concern? What's you all's concern in respects to? So Dr. Hughes mentioned in a report that you all were talking to the schools about how they're going to apply the code. But I'm curious what are you all saying to them about this, particularly with how you described how it spread. I'm thinking like boys and girls wrestling, football where they have tight scrubs, and the whole locker room thing with towels. What are you briefing the schools on that?
Can we take that?
Yeah, go ahead.
So we've started talking to the schools, and we've asked them to really focus messaging towards athletics at this point in time, and just be educating their athletes, letting them know that if they do develop any symptoms or if they had an exposure, to let their coaches know so that they could report it to the health points of contacts for the schools. Then they would work directly with us. I would expect it to happen at some point. But we'll see. I do feel like cases are kind of slowing down, knock on wood. But again, it's just a matter of time before we start seeing other parts of our population affected by monkeypox. Everybody's susceptible. Yeah.
Is there a cost for testing or vaccination?
No to both. Yep.
What's your? I'm just curious now. So, just curious your vibe because your vibe on. You've probably been here through this COVID, Ebola, SARS, H1N1, and that gap is probably about 6 years. I'm just curious at the rate that these are coming and how we need to message this to the public. I mean, COVID was such a big deal, but you got these pieces that are going to be constantly coming still. I'm just curious about how we need to be framing this, what people need to know about it, things like that.
Right. I think from an EPI perspective, we've been working closely with our Office of Health Equity to make sure that we're framing this in a way that is not stigmatizing an already marginalized population, but yet we need to be talking about it and not shying away from the fact that right now this is disproportionately affecting men who have sex with men. I don't know that there's a lot of appetite out there after COVID for general public. Just looking at comments after doing news interviews and things. The last one that I did, I know that Dr. Hughes has done a few as well. Everybody's like, oh, this is the next COVID, government overreach, et cetera, et cetera. And so I really tried to stress that this is not the next COVID, but it is important to understand how monkeypox is spread and the risk of monkeypox. I think you do see with the survey, again, we've got 600 or almost 700 people that have registered, so there is interest in this. And there is some education going on within the health department in the community at different locations in the next coming few weeks. So we're trying to target those that are at highest risk and still give some information to the general public, but not trying to overdo it, if you will.
So is it fair to say that we kind of need to be on guard? The scars of COVID are so that if we get I guess for lack of a better word, if we get scared of trying to worry about people saying about COVID, we're going to have other stuff flare up. I mean, this is like an aftermath of COVID. We just need to be
Right.
have a little bit of courage to make sure we don't get intimidated by.
Right, and I don't think that's the case at all.
Okay.
And we're closely monitoring the situation, and as we have, if we continue to have more cases and we start to see cases spread through casual contact or household contact, things like that, then our message is going to change.
Okay. I guess my last question, Leah, you mentioned a little bit, but you mentioned the numbers are still small enough, but from that helpline, similar to the needs from COVID, I guess right now it seems like food, other stuff. What's the driving needs you're getting from the helpline that people are calling?
On related to monkeypox
Yeah.
or COVID. So right now, the monkeypox kind of info line calls that we're seeing are predominantly focused on vaccination.
Okay.
Where am I on the list is kind of the question that comes about pretty frequently, or where to get tested.
Okay.
At least right now, those are the two biggest things, I think, because Justin's group is in contact with a lot of those people that might need assistance. So that starting there and then kind of moving down to the health navigation.
Okay.
And if I could just comment, one of the things that we're having difficulty with is we're coming off of COVID as a department, and much of our staff, we're still doing COVID, trying to pick up our regular activities, and now adding monkeypox into the mix, and we have no funding for monkeypox. And I think Dr. Hughes could probably speak to this more than I, but we're waiting to hear from the federal government, but often the virus is not waiting for the feds or for us to respond, and often our response is a little bit slower than the virus itself. So hopefully we can pick things up here soon.
Yeah, and to clarify, we have funding specifically for immunization, so we can. All of the funding that we've gotten so far has been really focused toward those vaccination efforts. So, for instance, when we want to work to put information out into an app, or we need to assist somebody who's having some significant needs due to their isolation, things like that, we really struggle to find the funding to take care of those sorts of things, because almost always our funding lags our response, unfortunately. So that unfortunately is a lot of people in a bind.
All right, Jim. Thank you.
Thank you.
Appreciate it. You got anything else under your report, Dr. Hughes?
I have nothing else on my report. Thank you.
Okay, then let's go to the presentations, and we'll begin with presentation one. And I like to set this up just while Dr. White is getting set. I see her on there. This is, I think, for the board to see. I think it'll be interesting in respects to the the action that we took for the racism as a public health crisis effort took us deeper into the social determinants of health and how some of those affect. We've had a lot of talk about clearly understanding how housing disparities can play into that, how general health disparities and other things. This study that Dr. White has been working on at Creighton, when I saw it, clearly kind of points out some of the economic pieces and how that can help. This is a project that's been going through what's called the Financial Hope Collaborative from the Creighton School of Business. Dr. White has been involved in the research piece, and Creighton's recently got some money to fund it to scale it up. They have some information from it that I thought was very interesting. I thought tied the economic aspect of the social determinants of health and what it would do. So I asked if she would present here, and I think it'll hopefully tie together with people when we see it. So with that, Dr. White, if you are set up and ready to go, the floor is yours.
Thank you very much for having us come to speak to you a little about the work we're doing. Can you guys see my screen?
Yes.
Yes.
Okay, great. So as Chris mentioned, we started this project in January, and Kevin Fuji and I are leading the effort, but we have a really fantastic team of individuals that represent a cross-sector collaboration. So we've got partners from the College of Business, social work, health and wellness coaching, we have physician champions, and statistical support. And the objective that we have is really to address some social determinants of health in patients with type 2 diabetes, and specifically financial instability and some of our lifestyle behaviors. So when we think about socioeconomic status, we tend to focus on income and salary, but we know that a portion of the health disparities we see in people with low income isn't directly related to their income level, but is actually driven by the stress in their lives related to their finances. So stress from any source we know triggers biological processes that cause immune dysregulation, inflammation, and potentiate chronic disease. But financial stress, uniquely, we know is associated with increased rates of smoking, alcohol use, poor diet, and sedentary behavior. So there's a fantastic book called Scarcity, and this theory of scarcity is kind of our framework for our project. And so this increase in unhealthy lifestyle behaviors that we see in low income can be explained by the limited resource model of self-control. And what this model says is, you wake up each morning with a finite amount of self-control, and people with less money, food, and time have more difficult decisions to make each day. So will I keep the lights on, or will I pay for my insulin, this week? And these difficult decisions exhaust self-control and result in more unhealthy coping types of behaviors. And this bandwidth tax is why more traditional health promotion interventions are often less successful in folks with lower incomes. And so the purpose behind our project is really to overcome one of those barriers by improving financial stability and then moving to addressing some of the lifestyle-related factors. So this is our theoretical model, and at the center of it is kind of the financial success program that Chris mentioned. So the financial success program is an evidence-based intervention that we know changes financial behavior, decreases financial strain, and as a result, we're looking to see what type of ripple effect that has then on health in terms of cortisol, catecholamine release, lifestyle behaviors, and ultimately how that ripples to weight, biometrics, and cardiovascular risk. So the program itself is an 18-month intervention. We're screening individuals and including those who have type 2 diabetes, financial instability, or food insecurity. And the first year of the programming, the emphasis is really on addressing financial stability. So we're addressing finances first because we know if we can overcome that barrier, we have better luck with some of our lifestyle behaviors. And so in the first 12 months, the individuals will undergo the Financial Success Program, which is a financial education and coaching program. They're also going to receive food from our food pharmacy. So we've partnered with Hy-Vee, and Hy-Vee will deliver to the homes of the individuals in our program. It's about $80 worth of food that a dietitian put together that includes recipes and meal prep ideas that we know really manage blood sugars quite well. Participants are also have access to a concierge financial social worker that helps them to decrease their monthly expenses, and this relationship extends into the entire 18 months of their participation in the program. So the first year, finances first, and then in the last 6 months, when we've noted from previous research that financial stability improves, we're shifting gears then and focusing on lifestyle medicine. So we have a health and wellness coach that works one-on-one with each individual to try to improve, nutrition, physical activity, sleep, alcohol, tobacco. And then during the last 6 months, they also continue to receive food from the food pharmacy. So we've been studying the Financial Success Program now for the last decade, and we recently wrapped up a Robert Wood Johnson Foundation-funded randomized controlled trial where we looked at the impact of the Financial Success Program on single moms with low income. And what we found was, on average, we saw an increase, a 20% increase in salary for the women who participated in the study. And they had improved financial behaviors. So they were setting financial goals alongside their financial coach, budgeting, reviewing their spending. And as a result, they increased their savings, on-time bill pay, reduced the receipt of shut-off notices and overdrawn bank accounts. And this all led to a decrease in financial stress. Women reported sleeping better, less stressed on their relationships. They were avoiding medical care less because of the cost. And then we also started to see some impact on lifestyle. And so we saw a 5% reduction in the rate of tobacco use, and also a reduction in junk food consumption in the women who participated or received that financial education and coaching. So we know that this program works, and so we wanted to couple it with a couple of other evidence-based interventions, the first being that food pharmacy. So food pharmacies, you have probably heard of them before, but the objective is really to improve access to healthy foods, not only to decrease food insecurity, but also to, the foods that we use are important too. So using foods that can prevent and manage chronic conditions. And there's some great research out of Geisinger Health in Pennsylvania that looked at patients with type 2 diabetes and the impact that food pharmacy can have. And what they saw was a food pharmacy, for 18 months of participating, which is the length of our programming, patients with type 2 diabetes experienced a 2.1% reduction in their A1C, their weight, blood pressure, and lipids improved. And then for those who were insured through Geisinger, they also saw an 80% reduction in healthcare costs to the participants that were insured through their Geisinger plan. And then lifestyle obviously is hugely important. We know, several studies indicate that if we can engage in healthy lifestyles, we can reduce the risk of chronic disease by as much as 78%. But we also know that few people are engaging in healthy lifestyles. So you can see in the United States, the number of people who are consuming a healthy diet, getting the recommended amounts of physical activity, avoiding tobacco, and really only 5% of our population is doing these three things at the same time. So there's a great opportunity, but we know that a significant barrier here to healthy lifestyle and folks with lower income is that financial stress that they're experiencing. So our hope is to decrease that financial stress and leverage that to engage in healthier lifestyles. Kevin, I'll turn over to you.
Thanks, Nicole. So from a research perspective, like Nicole was saying previously, it's this financial piece has been demonstrated to be really effective in low-income single mothers. But as Chris noted, a lot of our funding now is really focused on when can we scale this up and can we show those same kinds of improvements in other patient populations. And so looking at low-income individuals with type 2 diabetes and really not having very many restrictions on age or gender or anything like that, do we still see those same kinds of improvements? And again, that would be decreased financial stress, increases in income, and then subsequently some of these other pieces like improvements in health behaviors. So just to reemphasize what Nicole said, getting that baseline financial stress down and then adding on those lifestyle medicine pieces in conjunction with that food pharmacy benefit that they're getting throughout the course of the study, we're really hoping that we actually then start to see improvements and sustained improvements over time in health behaviors, and that this ultimately will lead to that third aim or demonstration of improvements in health outcomes. So from a diabetes perspective, we're looking more at that long-term marker of diabetes control, so that hemoglobin A1C, and really looking for that A1C goal of less than 7%. And so we're collecting data at baseline 12 and 18 months. Again, we're looking primarily at financial stress and income, those health behaviors, and then that clinical change in A1C. But we're also looking at a few different secondary endpoints as well. So self-reported financial behaviors. We want to know if some of these, are they actually utilizing healthcare less, or in some cases more, right? When you actually provide individuals with the resources, when they understand what their healthcare visits can do for them. And in some cases, I think we see an increase in healthcare utilization that's actually a positive thing rather than a decrease in healthcare utilization. We're looking at self-reported quality of life, some indicators like BMI and waist circumference, blood pressure, because we know a lot of times that's associated with individuals that have diabetes as well as lipids, and estimated cardiovascular risk. One of the things that is not on here, but that we're also collecting, is a lot of qualitative data. So we're collecting stories, kind of understanding that sometimes it takes a little bit of time for individuals to really get into certain kinds of habits. And yes, maybe we can reduce their financial stress in the short term, but it might even with that really good foundation in place, it might take them longer to start adopting healthy behaviors, or it might take them a little bit longer to actually adopt healthy behaviors in a way that's going to lead to improvements in actual numbers, in terms of numbers improvements, in terms of clinical outcomes. And we understand that. And so we also want to collect those stories, because we know that that's an important marker of how people are feeling and the improvements that they're able to make on an individual basis in their daily lives. And so, again, our target population, 300, we're over the course of our about 4.5 year study. We're looking to enroll a total of 300 individuals. Again, these are low-income individuals with type 2 diabetes, considered adults by our age of majority of 19 in Nebraska, who are not pregnant and do have the ability to speak and read English. We're looking at some potential additional funding sources to be able to expand to Spanish-speaking populations. But currently, just in terms of logistics and making sure that we're doing the things that we're supposed to be doing and that our intervention is set up in a way that's going to be most effective for people, we're focusing on native English speakers first. And then they're just self-reporting that they either have financial stress or food insecurity. So we do an initial social determinants of health screening for interested individuals, and that's one of our screening criteria to be eligible for the study. So currently we have 51 participants enrolled. It was a little bit of a slower start, but we've really picked up since then. Of these 51 individuals, 24 are actually Medicaid participants, Our first two cohorts of about 20-ish individuals have completed that initial 9-week financial education class. So that's a group class, and now they're on to one-on-one individual financial education coaching. And our third cohort just started last week. So we're kind of on a good, we're on a good upward trajectory here. And we're going to show just kind of a snapshot of some early findings. We don't have a lot of data yet since we just started at the beginning of this year. But this is data from a dashboard collected by our financial social worker. And again, this is just a snapshot, so you can see that top row, so to speak, has 39 patients, but 118 barriers. So about on average, about 3 barriers being experienced by the individuals in our study. And as you might expect, a lot of this, because it's part of our inclusion criteria, our financial or food insecurity in nature. But you can see that individuals also experience housing. Actually, maybe you can't. It's a little bit difficult. I know the words are a little bit difficult to see. But some of the other things that they're experiencing are housing problems, transportation, social isolation, maybe signups with insurance, behavioral issues, and other barriers. And in terms of the interventions provided for 21 patients that we just pulled out here as an example, you can see 140 interventions. And that kind of light green bar, a lot of these interventions are education or informational in nature. So maybe there are resources out there for the individuals to take advantage of, but they're just not aware of them. And so that's information that our financial social worker can provide. We'll also have a couple of stories in the next couple of slides. I'll illustrate some of the other information that she's providing. And she's also, in that purple bar, able to connect them to those resources when she's able to provide some of that education. And to kind of dive further into that, some of this might be application assistance for things like SNAP benefits, other social safety net programs. It could be medication assistance programs. But that's a lot of what she has kind of intervened on so far. And so we just have a couple of stories we wanted to share. So first we have Robert, and so Robert started our program. He had the stress of being several months behind on rent and utilities. He was getting about $1,300 a month from his Social Security and disability insurance, but his rent was about $950 a month. And so some of the education that our financial social worker was able to provide was that if you kind of had a rule of thumb that these rent or mortgage payments were about 30% of his income, that's kind of a good target to shoot for, rather than the about 73, 74% that he was currently at. She was able to connect him to that metro area continuum of care for the homeless, who helps with emergency rental assistance program funds, and he was able to get 3 months of rent and utility assistance. So through the course of her conversations with him, he decided to find a less expensive living situation, actually now budgeting based on that 30% of his income going towards housing. She helped with application assistance for SNAP, referred him to job coaching, connected him with some pantries. And so now he's getting ready to move and is getting the confidence that he's going to find a job that works for him, and that now he's able to budget accordingly. And by freeing up, as we know, some of those housing finances, maybe he's able to spend it on other areas of social determinants or even his own health care related to his diabetes. And then with Cheryl, she was somebody that was struggling to afford her medications, certainly a big problem. She has Medicare and a UHC supplement, and she was doing fine, but she hit that donut hole of coverage where she would have to pay everything out of pocket until she kind of hit that catastrophic point. And so it was going to be $4,080 that she was going to have to pay out of pocket. And so the financial social worker found prescription assistance programs that Cheryl qualified for, helped her fill out 5 applications. I think if any of you have seen some of these applications, sometimes they ask for a lot of information that I think an individual on their own might have a lot of difficulty going through. But when they have somebody kind of stepping them through the process and helping them get the documentation that they need, that makes a big difference in the person's ability to actually get assistance from these programs. And so you can see that resulted in an average monthly savings of about $480. And the financial social worker also gave Cheryl some education about insurance supplements this fall that are going to be effective January 1st of next year, even though she'll have to stay with her current supplement for the remainder of this year, but already kind of planning out to say, this is what you should be looking for. Here are the kind of supplements based on the medications that you currently have that are going to be most beneficial for you. And for the remainder of this year, CHI Medication Assistance Program is going, and she connected Cheryl with that program as well to help with some of those costs. And then finally with Patricia, our lifestyle medicine coach, has been attending some of these financial success program meetings and providing some additional education on her end as well. And so some of you may have seen an activity like this before called Sugar Shocker, where individuals are asked to match some of these sugary beverages with how much sugar is actually in those drinks. And so you can see that graphic below. And so Patricia was a regular soda drinker, and for her, it was a big realization that every time she was consuming a bottle of soda, that's how much sugar in those cups she was actually taking in. And for her, that was a really eye-opening educational piece. She's cut out soda from her diet, and she's lost 10 pounds since the start of the programming. And as I said, we haven't had these individuals in this program for very long. So to be able to take that first step and make that change right away has been really positive. And so you can see some different aspects that our program and our study has been able to help with, everything from education and really better understanding financial difficulties and how individuals might handle that, to providing assistance with getting affordable medications, and then some of those lifestyle changes that, again, we just know are really important. And so I don't know that we really talked about it. So our project is called the CURE Project. We are based out of Creighton University. Nicole and I are professors in pharmacy program there. And so as a Catholic Jesuit institution, one of the kind of central Ignatian values that is present is called Cura Personalis, or care for the whole person. And we really felt like that was a central tenet of what we were doing with this project as well. And so kind of adapted that, and it's how we came up with the name, the CURE Project. So we appreciate your time and the ability to share some of what we're doing. We're probably just as excited as Chris is, and appreciate the venue to do this. So if anyone has any questions.
Questions? Okay.
I see Ben. Ben has his hand raised.
Come on, Ben.
Thank you. This is an interesting study, and I completely agree with the premise and the expansion potential that it has for Spanish speakers, and particularly South Omaha, because I'm involved with a couple of aspects of my outreach, some of which is directly connected to my job with Douglas County as a contractor, but others of which I find myself thrust into because of referrals or issues that impact South Omaha and particularly the Latino community. One of these issues is the disparity, and the study that was done by Dr. Greenbooth, in fact, from Creighton University, the disparity of rent assistance. The need for rental assistance in South Omaha is, as much as anybody else in Douglas County, very, very important. Saying there's a disparity in the delivery of rent assistance or non-delivery of rent assistance, in this case, to South Omaha. And I'm thrust into the middle of that issue now, and I'm still having discussions with several entities, including Match and others, because I think there's a better way to deliver rent assistance, because as you state in your study and your conclusions, I agree that people who are labeled low income, who have financial stress, that financial stress impacts every aspect of their physical and psychological being. So it does have a big impact on their health and well-being. And so the premise is solid. There's another issue connected to this, and that is my opinions for South Omaha and I like what the outreach is doing, because I also work as an advisor to UNMC through Dr. Dialba, and we recently had a conversation, a meeting, he and I, where we talked about, in my opinion is this, when they train doctors, for example, and because he deals with a lot of incoming freshman students at UNMC, I said to Dr. Dialba during our conversation, if a physician, in my long history of occasionally coming in contact with doctors, I find it the common practice for many doctors to do their analysis, their specific dealings with a patient, and then leave the rest of the health delivery to the nurses and others in the room. And I was talking to Dr. Dialba about training for physicians, and I was saying this to him. I said, look, in my estimation, just as a layperson, it would be interesting if doctors would receive early on training so that once they speak to a patient, they consider the whole patient, not just the medical issue that confronts the patient. But as soon as they finish with their medical analysis, turn the rest of the care to others on their staff to say, now let's pursue the conversation with this patient regarding the total package of that patient brings to us, the well-being of that patient, what they bring from the home environment, what other issues are impacting their medical situation. I would like to see doctors be able to refer immediately after they do their thing with the patient, to then defer to others in the room to say, okay, now we want to do a complete analysis of the patient to see how else can we help them recover and to get to a state of a better medical situation, both physically and psychologically. So there's a number of issues that I think still need to be worked on. And in this case, I'm concerned mostly about the Latino community.
Thanks, man. Anybody else online? Okay, well, like I said, I felt like this needed to be put on the radar. I thought it was good to know. Dr. White, can you? I know there's the program's history. There's been individuals from the mix of the class right now is pretty mixed between North and South Omaha. Is that correct?
Right now our recruitment has been primarily from the CHI clinic across the street from Creighton, but we do have plans to, we just wanted to stand up the program and roll things out, but we do have plans to expand that through a number of community partners that would expand our reach into South Omaha as well.
Okay.
And we have brochures and information. If you have community partners that you would like to spread the word among, we would be happy to share information about that with you as well.
Okay. You got one more question, Dr. White. Let me ask you though before you go. Is it possible for us to get a copy of that presentation just to have on the record here?
Yeah, sure. I'm going to remove the third slide because I stole an image from somebody else.
I got it. All righty. Thank you.
That was my question. How do we get in contact with either of you, and how does one sign up for the study?
Yeah, so I can share our email addresses and also share, brochures and the number for our research coordinator and the email for our program with everyone. And really, if someone just calls and they meet the eligibility criteria, then we're enrolling on a first come, first served basis. So.
Carlos, go ahead.
Yeah,
this is more of a comment in general, spurred by this conversation. NAPA, the regional planning agency for the Omaha Council Bluffs area, is really interested in pursuing additional information and additional support for any of these social determinants of health. We've talked several times about how this work could go forward, and some of the things that we're doing is mainly focused on transportation, and that being one of those determinants that prevent good, healthy living. And so we're very interested in this and very interested in the role that transportation plays on social determinants of health. Look forward to getting your information, Dr. Wright, and the researchers at Creighton. Happy to continue the conversation and looking forward to continuing a lot of this work moving forward. Thank you.
Yeah, wonderful. Thank you, Carlos.
Thank you. All right, Dr. White, thank you. We look forward to probably a little bit once you all dig in and get some more to see what is resulting from the first year.
Thanks
Please.
again for having me.
Thanks. With that, we'll go to item B, and I'm glad to start reconvening the reports back from the systems on community benefit. I'll turn this over to Jeannie if she wants to do the intro.
They have some materials that they'll go ahead and pass around as well. But first introduction is, this is Megan Conley, Vice President for
Community Pediatrics
and Child Health. I always want to put community health together at Children's Hospital. And I have the pleasure of joining the Community Health and Advocacy team full-time in April, and want to provide the opportunity for children to talk about their community benefit, as well as their implementation strategy plan based upon the Community Health Needs Assessment last fall.
Thank you, Jeannie, and thank you to the board for inviting us. Thank you, Dr. Hughes, for the invitation today. Children's is committed to child health and how we can interact with our community partners to better that. So today, we have two of our members who are going to talk about some of the activities that Children's is doing this year and for the next few years, and we'd love any of your input and questions. So I am going to introduce Jen Patton Benson, and Jen is our community benefit manager. And she's going to tell you how we are doing with our community benefit. Thank you, Megan.
Okay, I have a couple of slides here. Thank you. Okay, so this is just a first slide on our Community Health and Advocacy team. So you just met Megan Connolly. Holly Dingman, the Director of Community Health and Advocacy, is here as well as myself. And Chrissy Tonkinson is a member of our team who's not here today, but she does our data and evaluation for our department and for a few of the activities within the hospital. The first slide, we're going to just do kind of a quick overview of what community benefit is, and I'll read you the definition. This definition comes from the Catholic Health Association, which is basically the authority on community benefit. Community benefit is programs or activities that provide treatment and or promote health and healing as a response to identified community needs. They increase access to health care and improve community health. To put it in more plain language, the work of community benefit documents how, for us at Children's, it makes investments in the communities we serve. It helps us tell this story through financial investment, impact data, and real-life examples. So as we dive into our community benefit report here, community benefit expenditures are reported annually in the organization's 990 tax return, Schedule H, and also reported to the Nebraska Hospital Association. Internally, we produce a report that's designed to show a breakdown of costs and summarize community benefit activities. We just passed around a copy of that most recent report. The report is from 2020, so community benefit reporting is always a year behind. 2020 is the last full year we have of data. We are working on the 2021 report right now that will actually be available in December of this year once the financial audit is complete. And then the dollars that we report are reported minus any offsetting revenue like contributions, grants, and patient fees. So this first slide is a picture of community benefit at Children's Hospital in 2020. So you can see that children spent about $129 million net of any offsetting revenue in community benefit. We divide our report into three broad categories: broader community health, uncompensated care, and community programs and services. The hard copy of your report there dives into each of these areas a little bit more and kind of provides a further explanation for those. The one I want to share with you for the purposes of this presentation is just a little bit more. Sorry, I'm going to go to this slide first. Just a little bit more on community programs and services. So we spent about $1.8 million in community programs and services, and this is a category of programming that is designed to improve the overall health of the community. It serves people in the community that aren't necessarily children's patients, and this is just some examples of our programming. Within the 2020 report, you'll find stories on our COVID response for back to school. You'll also find a report or a story on the Vision Mobile, as well as the Patch program. And then this is just some examples of some of the other programs. The next slide we have here is a look at community benefit more broadly. So this is the past 5 years of community benefit expenditures at Children's. And so you can see the top line there is the total community benefit amount, broader community health, uncompensated care, and then community programs and services for each of the years from 2016 to 2020. You can see that there's pretty much a steady climb, except there is one exception there that jumps out at me almost immediately, and that's the uncompensated care in 2017 and 2018. There was a change in the Medicaid payer structure that year. So it looks like there were some accelerated payments in 2017. 2018 then had a lower expensed amount there. When you average those two, they even out to about $49 million. So it looks like there was just a little bit of an accounting issue there. So overall, you can see that things are steadily climbing to that $129 million total expenditure in 2020. And then my last slide is really on the future of community benefit. So in 2021, Children's had defined community benefit and health equity as priorities in the organizational strategic plan. So providing a greater focus on both community benefit and health equity. I am actually the first community benefit manager full-time for the organization. I started in November of 2021. And my role, my first goals really are to kind of standardize reporting for the hospital, for the organization, implement Sabisa. Sabisa is a database, a proprietary database that we use to track expenses and data collection for community benefit programs, and really integrate the community benefit message within the hospital. So I spend a lot of time with the various programs in the hospital learning about their activities and their expenses and gathering their reporting. Going along with that, we have new oversight and structure for the community benefit programming. We developed with the help of the Catholic Health Association's documents and guidelines, we developed an assessment of best practices for community benefit, and we administered that assessment with our community benefit steering committee. The steering committee is made up of hospital leaders who have some oversight or interest in community benefit. So I think we have about 15 people in that committee. They provided their feedback on the assessment, and then from there, we were able to define 5 key priorities. And the first of those key priorities was to adopt a community benefit charge or commitment statement. And so this commitment statement, I'm excited to share with you. We just finalized this here earlier in August, and I'll read it. Children's Hospital and Medical Center commits to improve health equity for all children. Our experts collaborate widely, engage our community, advocate tirelessly, and invest intentionally in the future of all children, particularly those in greatest need. And so this community benefit statement will really serve as the foundation for our communications, both internally and externally, as we establish that awareness and focus on health equity and community health in general. And with that, I'm actually going to turn it over to Holly Dingman to share a little bit more about health equity.
Good morning.
Good morning.
Thank you for this opportunity to be here and share our work. This is a pinch me moment to be able to present with Jen Benson, who is our first community benefit manager, and to bring forward a new direction that Children's is going intentionally in community health. I have the pleasure of serving as Children's Director of Community Health and Advocacy. And the work today that I'm sharing is at the heart of our community benefit work. This is our implementation strategy plan. We have new impact areas, and this is a culmination of about 18 months of behind the scenes conversations, defining. So I'm excited to be here, and thank you for the opportunity and the invitation. This has been our timeline that we've been on. A year ago, we conducted the Child and Adolescent Community Health Needs Assessment. This is completed in partnership with Boys Town and Douglas County Health Department and other community entities to really understand the health needs and in our community. From that data, we prioritize the community health needs that we as an organization want to dig in on. And prioritizing is important because the needs are great. This year, we've brought forward 4 impact areas for child health. They're not going to surprise you based on all the conversations that you've had in the past few months of the pandemic. Our pediatric mental wellness is a priority. That was bad before the pandemic, and it's worsened. And then we are bringing forward 3 new impact areas around social determinants of health. Children's wants to dig into financial stability, food security, and healthy housing. And those impact areas have been written into our implementation strategy plan, which is our blueprint for the work ahead. It's a 3-month or a 3-year plan. We are in year 1, and I will tell you a little bit more about that work. That plan was approved by the board in May and posted on the website. And we are now in the process of digging into it. We have for the first time, creating this implementation strategy plan convened many internal experts and entities in this process. We had over 30 departments and 70 of our internal experts weigh in on the creation of the implementation strategy plan, and we are continuing to engage them through action teams. So core to our implementation strategy plan is health equity. And as Jen mentioned, it's now part of our community benefit statement. This really started to show up through our enterprise-wide strategic plan, which was developed by, in coordination with thousands of community members and leaders with Children's, bringing forward equity in a way that's meaningful. And so we knew that we had to standardize the language. What are we talking about when we say child health equity? So we adopted the National Institute of Health's definition of underrepresented child populations. Children of color, children with disability, and children with disadvantaged backgrounds are our primary focus. This will be consistent through future communication and messaging, but also more importantly, data collection, reporting, and deciding how we make decisions and investing our time and resources. This equity focus is also showing up in workforce training. So we have an amazing culture and inclusion manager within Director of Culture and Inclusion, Siobhan Washington Krauth, and she is doing unconscious bias training for all leaders and is rolling out training throughout the organization for all of our employees. Our community health and advocacy team is bringing forward a health equity primer to get our action teams understanding what is equity. When we say upstream, what are we meaning by that, and how does it complement traditional clinical care? And then we're rethinking and reinvestigating how we make decisions within our community health and advocacy programming, partnerships, and sponsorships. So this really will be the next story that I get to tell you. But further into our implementation strategy plan, we have 4 general areas that really go across all of our impact areas. We are entering a due diligence phase, which means we want to know what we don't know. We want to take a step back. 3 of these 4 areas are completely new for Children's. And we just heard Creighton's amazing work with the Cura Project. We have to learn who's doing the work, who's doing it well for child serving and marginalized, underrepresented child populations, and then what data infrastructure is needed. So this is our due diligence phase. It's about we anticipate for a year and a half that we'll be doing discovery and research. Children's is also looking at our employee population, our workforce for both professional and personal needs around social determinants of health. We surveyed employees about a year ago and found, yes, within our own employee population, we have needs. And so we've brought forward a partnership with the Chamber of Commerce to have a Grow Navigator on site twice a week to help bridge that gap for Children's employees into community resources. And we also forged a new partnership with Habitat for Humanity to offer mortgage-ready assistance for employees. June 1st, we launched Be Involved, which is our community volunteer program. A program I'm excited about because it brings children's time and talents into the community. Full-time employees are given 8 hours of volunteer time off annually. Part-time are given 4 hours of volunteer time off annually. And in the first 2 months of Be Involved, we've had over 30 of our employees go into the community and contribute over 100 hours of volunteer time. And it's self-serving also, right? When we have employees that can give and feel connected to community, they're happier in their employment as well. So it's a win-win-win. Screening, referrals, and navigation are core to the work in our implementation strategy plan. It's work we're familiar with. We do this on the daily in clinical, but taking it a step further of really thinking about the systems around screening, referrals, and navigation, and being honest with, are we getting families the right resources at the right time to address their needs? So across all of our priority areas, we're digging into screening, referrals, and navigation. And then another theme across is policy and advocacy. What can and should we be doing to elevate the needs and the voices of children and families for organizational change, but also local, state, national policies? We have an amazing leader in this area, Liz Lyons. She's the Director of Government Affairs and Advocacy, and she's very integral in this policy space. This is, these are some, I don't know which, extra slides. Okay. It was a little bit out of order, so I'm just thinking if I missed anything. I think that's it. Really, I hope I have given you copies here, and I have some extra copies. We are looking forward to making connections with other community partners. If you know of community partners that are aligning with our priority needs, and you think don't miss this community connection, please let us know. All of these documents and how you can find us is childrensomaha.org/advocacy. It's a pretty simple URL. And we'd love to entertain some questions.
Okay, I know this instinctively, but I need a little bit of clarity because even though we haven't done this in a while, for those that may be new, you all do your survey separately. Like, for instance, we partner every year. You have the main health systems. Yours is separately because it's specifically children.
Yes.
Now, even I need a little clarity just on reading this because for some reason, when you did this revamp when you added the other three pieces, right? So the bigger needs assessment, it's done. It asks the questions to the public. It feels it's broader, general pieces like it's everybody. Yours angle starts up from the kid and goes out. But just for some reason now this year, the survey is toward children, but really to solve the issue for the child, you got to serve the whole family. So I guess I'm just trying to get your view. And this is for some reason the first time that it's hit to ask this question now because of these other things you put in there, those other three. Where do you see the results of your survey crossing with the bigger one that goes?
Yes.
I mean, some of it is the same, like the bigger one will have, I mean, just can you explain just the base of it, the emphasis that is being put on the mental health piece and the adult one, how yours is a little different but works with that?
Yes. The best way to understand it is that we plan our two surveys in the community to complement each other. So we use the same research partner, PRC, to do our surveys. We have crosswalked, question by question, painstakingly crosswalked. But it's important because there's no need to duplicate. And then we continue to get together with the Wellbeing Partners happens to be our convening entity. They host the Regional Health Council, and so we are often bringing forward the data to look when do we need to use adult data to justify, and when do we need to bring in some of that child data around these priority issues. So they're very complementary.
Okay. Can you pull item slide 6 back up, if we can do that? Well, I got it listed here, slide 6.
The line graph. Okay. Yeah, there you go.
Okay, Ms. Benson, you said can you explain that, what you said about the Medicaid piece?
The dip.
The dip, yeah.
Yes. So understand, I wasn't there in 2017-18. I'm basically telling you what I was told. But essentially, there was a change in the Medicaid payer structure in 2017-2018. And so there were some accelerated payments in 2017, which resulted in lower payments in 2018. When you average those together, they're about $49 million a year. And so they even out. It's just the way that the cash was distributed in those 2 years, if that makes sense.
So that's a state change, I'm assuming?
Yes, I believe so.
Okay. So the other question I just got from the report, so the bottom line, which is, because this is the question I've asked everybody, but I'm going to ask. Because the peeve that I had usually in the past is the institutions are fulfilling the technicality of the law, but I'm trying to figure out what's the difference here, because in the slides, it seems like there's a difference. There's some programming that seems like institutions are using the money, but the community benefit is more for an internal program they have to boost it up. Now, your lines tell me, is the broader community, you got the bottom line that says community programs and services, and then you got the broader community line. Are those in the same family? And when I'm saying, like, I'm assuming your broader community line is a line that's funding areas of needs that's outside of children's, I guess, own self-interest kind of. Is that fair to say? Or which one? Or is that the bottom line? Programs.
So the
that slide. Okay.
Broader community health in general is so subsidized health services are things like home health care, behavioral health, and it's in community benefit language, it's category C. Those programs are they cost more than we receive for those programs.
Okay.
So we receive less in payment.
So the orange category is the broader community stuff that's supporting.
The orange category, the gold there, are community programs. These are activities that we do. Our hospital invests in these activities, and they're for the greater community. Yep. So like Go Noodle, for example, is it's a physical activity online program that you'll find in classrooms all over the state of Nebraska. So we fund Go Noodle so that the schools can use it. I know my kids use it. School Nurse Mentoring is a program that we have where, and it's funded by the in part by the Nebraska Department of Education. So there's some offsetting revenue to it. But School Nurse Mentoring is essentially matching up kind of seasoned school nurses who have been school nurses for a long time with new school nurses to help them through their first year of work as they kind of navigate their role.
Okay.
Yeah.
So if you go back to the line slide, did you all, when Medicaid expansion passed in 2018, that didn't affect you all more? Did it because of when it expanded? Did that touch you all? Because I'm assuming, I don't know the details, most of the children's clients were covered by CHIP and other stuff like that. So when Medicaid expansion passed, you all didn't really feel any big bump in it.
I'm going to actually give Megan a chance to answer that question.
Great question. Children's is the largest Medicaid provider. We have the most Medicaid patients in the state. And that's just because of it's more age-based than condition-based. And so what we are seeing is the latest expansion of Medicaid. We are just seeing some effects now. I cannot answer this 100%, but I don't know if back in 2018, if we saw that from that specifically. We're seeing more things happen now. But the legislature this year addressed some of our issues. For example, there was a law that was passed that they're increasing Medicaid payments of behavioral health 15%. So this line next year, when Jen reports on that offset care, that may look different. Does that make that answer your question? Okay.
Yeah. Sorry, go ahead.
How does Children's communicate with the other healthcare systems in terms of the pediatric hospitalized population?
Pediatric hospitalized.
Well, right.
So, can you give me an example of?
The other hospital systems still have pediatric patients, correct? So I'm just wondering, in terms of healthcare systems, looking at the pediatric population in this hospital, do you talk to UNMC, Mercy, Bergen, et cetera, specific to the pediatric hospitalization in terms of community needs, et cetera?
That is a great question. You know, Dr. Hughes, I'm sorry to say this, but the pandemic did bring some things that helped us. And one of the things that it did do for us is show how important communication is between the health systems. So Boys Town, for example, us, UNMC or Nebraska Medicine, we have the most pediatric beds in our city. So we take pediatrics from the other hospitals, like you mentioned, Jenny Ed, Mercy. And we do communicate. And when we're looking at our community space, that is one thing that we don't want to compete. We're all here for child health. So we are doing that. The pandemic helped us, and we continue to grow.
So my understanding for the adult side of the community health needs assessment was like the community members that were participating in this were not able to really rank the social determinants of health as a priority area. So I'm just wondering, is that different with the children's side, the pediatric side of it, where they are able, because it looks like these are you guys' priorities, where the others is kind of like access and social determinants of health are kind of part of it, but you guys are making that a main focus?
Yes, and I have some copies of the data that we summarized for each of those priority areas. And there were certain data that pointed to those priorities. The stakeholder survey brought forward mental behavioral health, and then that was number one. Lack of family supports and services was number two. We heard it really strong in those community stakeholder surveys. And then when we looked at the data specifically for those social determinants of health, the health disparities were so striking, it just really reinforced root cause of the that we needed to focus. Coupled with the children's strategic plan was saying, we know we should and want to focus on equity. There's something going on there. So that was really the spotlight. And then when we looked at the data, it just really reinforced those priorities.
I mean, it's definitely important. I'm just wondering how you guys were able to
Yes.
put those on the priority areas.
Yep.
And then just about the Grow Navigator for your employees, can you kind of explain what that program is about?
Sure. Do you want me to take a stab, or do you want to
Either
describe?
Either one.
I'll start, and then Megan, you tell me what I've missed. So this is a program through Chamber of Commerce, and they hire trained social workers as employees of the chamber, and then through a partnership agreement, that Grow Navigator is on site serving our employees. Anything. The laundry list of needs that employee has outside of what Human Resources already offers to employees. It's completely confidential, so it doesn't go into the employee's record. We knew that was going to be a potentially sensitive sticking point for our employees, and so the way the Chamber's designed it is really wonderful because they're trained professionals, very connected to community, and yet on-site, very accessible, and appointments can be in person or via email. They work until they resolve that issue with the employees. What did I miss?
You covered it well. One thing that we were very attracted to it was the program doesn't just give a card that says, here's a food pantry, here's a list of food pantries. They actually make sure the employee has transportation to get there, and then they follow up to make sure they were served. So it's a full cycle. It's not just information given. So it is like a social worker for our employees.
Can you go into the survey a little bit, how we identified adding the Grow Navigator?
Yes, with our new senior leadership at Children's, Chanda Chacon is our new CEO. She's not new anymore. She's over a year now, but she really has a passion for community health. And when she engaged us and said, these are some priorities that we need to look at, we need to respond to the survey that we took, or the community health needs assessment. But she said, we need to make sure the employees who are helping with this are also helped. So we looked for a survey that had been validated. So we found a survey, I believe it was from Duke, and it was a 10-question survey, and we gave it to our employees. And then our employees answered, and it was about food, it was about housing, it was about how often do you worry about paying for rent, just the social determinants of health questions. So we surveyed around 3,500 people. We had 1,000 responses, which we were really excited about because they were pretty personal questions. We did not ask for their name unless they wanted to put it. There were 2 questions that were related to violence. And so we made sure that if they needed help, we could follow up with them. But we took that, we made our plan. But one thing, when we look at equity, we did not do well because we gave this survey in English only on a computer, and we did not check the reading level. So when we got the survey back, we looked at it and we thought, geez, there's a certain department that we would have thought would have had high needs, but it's not showing that. In fact, not many people took it. So we went to their leader and we said, your department didn't have many responses. And our leader said, well, some of my employees can't read. Some of my employees can't read English, and some of my employees can't use a computer. So that was somewhat like a semi-truck that hit us because that was equity in real life in our organization. So we very much now look at everything with an equity lens. We try. We're probably not 100% there yet, but we very much try.
Anybody else? Well, thank you all. Even though it was like a 2-year hiatus, at least when I recall from the last report, you all took some big steps. I appreciate that. And I might be following up once I get a chance to dig, just for some curious questions, but I thank you all for the time. Anybody else for sure? All righty. Thank you all for being the first. That's always the hardest.
Thank you.
All righty. With that, does anybody have any questions from the department reports? All righty. Then if you're not, just know for the record, the next board meeting, September 21st, here. If everybody can stay real quick, I just need you for 2 minutes for executive session for personnel, and then we'll go from there. So if that's the case, I'd like to ask for a motion to go into executive session for personnel.
So moved.
Motion by Gray, second by Weiss. Roll call.
Rogers?
Yes.
Weiss?
Yes.
Jones?
Yep.
McNally?
Yes.
Gray?
Yeah.
Wade? Yes.
And just for the record, Sunday and everybody there, when we reconvene, there won't be any action. So this is pretty much it. We'll just reconvene and adjourn. So just note that for the record. All right. Thank you all. See you.